Hello and welcome to episode 6 of Auditing Antics podcast. So today we're going to be talking about the revenue cycle and what it looks like and what it means to have a healthy revenue cycle. So, one of the things that I saw recently this week, Michelle, that really got me thinking about this was the notification that Blue Cross Blue Shield in Michigan is going to really stop. They say that they're going to hold true to a policy that's been in place and maybe just not used up to this point as much. But basically, they are saying to facilities that they're not going to be able to just blind appeal. So that got me thinking because a lot of times when I work with clients in the revenue cycle space, it's because something is broken, there's disconnect somewhere, and it's not working. Just for transparency here, for me, I have never been a day-to-day biller, for example, in all of the years of experience I had around the revenue cycle. But I'm very familiar with what it takes from the beginning when that patient is scheduling through the time of the patient being seen, and then the big part of compliance that we deal more heavily in, which is documentation, coding, billing. And a lot of times people are looking at that as being the end point, and that's not the
Mhm.
end point. The AR piece is a very large piece. And one thing that I find frustrating with my clients is that when they are needing help with billing, there's so many organizations out there that offer the services, but there's not quality work there. And it's very tricky to find a company, which is very sad, but it's tricky to find a company who will even go in and dig properly through denials in the back end of that AR. So I want to explore that today from the internal perspective, if an organization has their own staff, or externally, and what that looks like if you are outsourcing that. Now, one of the main things that I find when we're looking at internal versus external, a lot of times people are thinking, oh, we can be hands off if we outsource this. Or internally, the other thing I find is that practices or organizations are not wanting to pay a lot of money for somebody in that position. And Michelle, to me, that's a big problem because these are the people that are going to be working the claims that are going to depend on whether or not your revenue is coming back in. And to me, that is not a quote unquote lower position. This is a
Mm-mm.
professional position that requires very good attention to detail, organization, having skills to prioritize. And sometimes, this is not the type of thing where you can just hire somebody off the street and even train. A lot of times people don't even have the basic skills. And, what are your thoughts on that, Michelle, looking and making sure, even from that hiring perspective, that you have the proper person and that you're valuing them?
Yeah, so I think a lot of times that comment you made about, just hiring anybody off the street, and they really are a valuable part to the revenue cycle. And I think a lot of times this is something that is not taken in consideration. And people have different systems that they use, and they're like, well, we have different rules in place that will tell them exactly what to do. But that is not always correct. So you have to make sure when you're hiring people, they have some type of familiarization with the AR process. Just like when we hire coding and auditing staff, we make sure that they have experience in those areas. They have specific training. As coders, we have to get certified with our CPC certification. Um, you have to make sure that you are applying those same thought processes to your biller, because at the end of the day they do need to have a certain level of coding knowledge to be able to appropriately evaluate denials and resubmit those denials. Because I can tell you, I used to work for an organization, and in that role, I spent some time shadowing with the insurance department where they were processing claims and denials. And as I'm sitting there, I was I was absolutely flabbergasted because of what I sat with several different people, and these people were just like, "Yeah, we just go in here and we'll add a 25 modifier on the E&M and then see what happens." Or I'll just scroll through the note, and if I see this diagnosis somewhere in there, I'll add it. And I'm like, "Hold up. You
Yeah.
just pulled that diagnosis from the patient's past medical history."
Yeah.
Like, this is not okay. And then, as part of that job, what I ended up doing was providing education in the area of CPT, diagnosis, and modifiers to different parts of our revenue cycle, which I think was very beneficial. But as I was sitting there, I was just kind of like, oh my gosh, I can't believe, they really didn't have any direction as far as how they should be processing these claims. There were rules set up in the system. It was epic. There were rules set up in the system that said, if this is here, this is what's wrong. And I can tell you that that was not always the case. And it really created this process of having, submitting, resubmitting the claim, and then getting a denial again because nobody actually opened it up to see what was wrong with it. They were just doing these, things to try to just get it out back out the door quickly. So I think that when you're going through the hiring process, first you need to stop and take a look at what are the practices and what are your current billing staff doing? How are they evaluating the denials and what are they doing with that information? Because you have to have a process in place to be able to identify people who are going to be able to follow that process. I am a strong believer that if somebody is willing to learn and willing to learn to work, they can be taught to do this. So I think that, having experience is great, but you also need to look for those qualities. Are they able to take direction? Are they able to be a critical thinker? Because those are things that are necessary when you're processing denials and when you're working as a biller. You have to be able to look outside the box and also recognize when, hey, this isn't something I'm going to be able to handle. I'm going to have to phone a friend for help. And also be able to recognize a pattern. Maybe the same CPT code is getting denied over and over and over. Maybe we should stop, take a look and see why they're denying, and is this something we can prevent? So that's what you want that's what you want to look for in somebody that you're hiring as a biller. Somebody who is able to identify problems and patterns, be a critical thinker, and know when it's time to call somebody else in to help.
Yeah. And, that's one thing too. You brought up a really good point about the differences in job positions. So, one of the things that I find that can be very frustrating when I'm working on, we call them revenue cycle reviews. So, I'll go into a practice and look at all of the processes, all of the policies they have in place, really try to pinpoint what every department is doing or job description is doing to see where the disconnects are and why the revenue is hurting due to the current structure of how everything's working. And one of the things that I find is that not everybody is recognizing the fact that coding and billing are two very different things. And just because somebody is there in the capacity working as a biller does not mean that they have coding background. And it also does not mean that it's their job responsibility to know the coding rules and to fix that. And there's a lot of things that happen surrounding just that concept alone, because sometimes people are put into positions and they don't have a choice. They don't really know the difference and they're just doing what they're told. But,
Mhm.
that's we won't dig into that side of it. That would be a whole other episode, so I don't want to go too far down that path. But the point here is that they're two different things. So when we have billing staff who are going in and working edits in a system, let's say, for example, the PM system brings up an edit for a bundling and they're looking at the 25 modifier, or they're looking at a diagnosis that has an edit that it's not medically necessary. That person should not be the one who is making that decision if they are not a coder. That's something where workflow within that practice needs to be looked at, so that, things are supported in documentation.
Hmm.
And one of the things that I also stress when I'm working with organizations that don't have actual coding staff is that they are making the decision to put that onto the providers. So the provider has to have that training. They have to know from the compliance perspective when that modifier is appropriate, when it's not, when the patient's there just for a procedure and they shouldn't be adding it. That's not something that should be falling onto the shoulders of billing staff who don't have, by the way, proper resources most of the time.
Hmm.
A lot of times when I'm working with teams that are struggling with these things or have a big backlog of denials, they don't know the billing rules, and their employers also not even giving them access to different coding tools. So we'll bring up, Codify. That's what we use as Codify through AAPC. And, all of the different coding softwares, they have what's called that NCCI edit checker. That is important to know how to use that, to know what those things represent, because that can be causing issues on the back end. Even if claims are paid, it could be a big compliance risk for external audits. So when you were mentioning, for example, with Epic, I've heard people say that they'll go through training and they're told, stay in your
Yeah.
lane when you're working work queues. Absolutely not. You cannot just look at an edit and apply something that an edit is telling you to apply to bypass it and move along. You have to apply, like you said, critical thinking. We have to be diving in. We have to see if it's supported in documentation, and we just need to make sure that everything's there and good. So, all of these things come to the point where really whoever's making the decisions regarding billing, whether it is an owner, a physician owner, whoever that is administratively, they need to really recognize this. And
Yes.
one other thing too that I find is that when work is outsourced, they have the same issue because they're also thinking at that point, well, I outsource my billing. So, they're taking care of it for me. They don't even know who that company has employed. There are a lot of good companies out there that are very hands-on in all of this, just as much as we are, so it is okay. But billing is not there as a safety net. We have to look first to see how that practice, even facility. I work with large hospital systems that choose not to have coders.
Hmm.
Scary, yes. Providers are mad, yes. But it's the reality. So we have to look at it from that education standpoint. Again, all of this goes back into making sure you have your external audits done and you're being preventative from that compliance perspective. But this is really the root cause of a lot of problems that come about within that revenue cycle. Now, thinking internally, Michelle, what are some things, if there is that internal team, what are some of the things that can be put into place to make sure that, that pulse is being checked, that we know that things are running smoothly, that, there's not issues. Again, worst thing is that usually people are hands off and they think they hired,
Hmm.
one person to do billing for 15 providers and don't understand why it's not working. So what
Yeah.
are some of the things people need to start thinking about to be more active in their own revenue cycle?
So I really think that first of all, it's important that even if you aren't going to have a group like a coding staff to review 100% of your claims, that you still have a department of trained coders and auditors to be looking at things like revenue capture. So let's look at the front end of this. uh, Revenue capture. Are we are we capturing all the revenue, and are we capturing it correctly? Is somebody going through and looking at, I know, back when I used to look for a facility, we worked as a coding department, but we also oversaw different specialties. So part of that was I was on a monthly basis looking at just some of the high dollar things. Did the quantity seem right? um, did the modifiers seem right? Did it seem right, the number of modifiers that they were submitting? Do some internal auditing. Make sure that on the front end, things are going out the door correctly. And then also take that time to review your denials. On a monthly basis, get a list of what's being denied, take a look at the most common denials, and see, are they preventable? Can you put things into place to prevent these from denying? As you know, denials are very costly. So having to go back and rework that costs your practice money, your organization money. And a lot of times these are things that can be caught on the front end. So whether it be a modifier or a diagnosis for a specific procedure, you
And
can tell.
Michelle, can you talk some about, because I know you've dealt with this even recently. Can you talk some about how you've noticed that different issues coming through in the coding and billing side is driven by the way a system is set up? So I said PM system, the practice management system, this is where the claims are being processed. Can you speak a little to what you saw recently? Because that really is something that even goes outside of, us having to meet with a provider. Sometimes we have to meet with the tech team, the IT team, the vendor, if the vendor has outside support to get these things
Yes.
fixed.
Yes. So, um, Epic, for example, they are really famous for saying we can automate this. and and saying, similar to what you said, stay in your lane. But basically, if it's on there, it's supported, or things like that. And it can be a workflow issue for sure. It could be a template that's set up to automatically drop certain CPT codes. It could be something that the system automatically adds, which is just beyond me, because I can't think of much, Stephanie, in the coding world that could be applied across the board in one scenario. There is so much subjectivity in the coding world that automating something just seems a bit odd to me. Um,
With the CPT or the HCPCS codes, yes, because for example, when G2211 first came out, we saw so many practices where it was automatically applied to every patient across the
mhm,
board. Now, one thing I will say to automation that is good, but you still have to look at it with compliance, because when there are specific templates, for example, I have rheumatology clients who are able to automate their joint injections, but
yes.
they pull very specific templates for a joint injection. And then what I had found at times with the audit process is that the language of the drugs, for example, was not pairing up with the CPT code. So with injections, we need to know where that site of injection is taking place, that origin of insertion. So if that template is not set up to prompt the provider to tell us tendon, tendon sheath, muscle, joint,
Mhm.
we can't make that assumption. And I've definitely had times for sure, when I work with my clients, I tend to know their IT staff as well, because Like I
Mhm.
said, that can be an outcome where in that situation I had to go back, work with the IT department, really break down the template they were using and look at how it maps into the final version of the note. So
Yes.
yeah, with documentation, there are times where automation of a CPT code dropping can be fine. But like you said, when a CPT code just drops automatically to things, we have to do that research and find out where it's mapping in, because
Yes.
otherwise we're going to have issues. And as much as the EMR systems and the PM systems are looking at this from an effectiveness perspective, trying to look at the automation,
Mhm.
they don't always have full compliance input on that front end when they're working on building it. So that's really where, again, external audits are extremely important because it's really attached to everything that's being done.
Yes, I do think that the audit process is key. It goes right along with managing your denials because you have to be able to identify problems before they become denials, before they become that extra expense burden on your practice. And one other thing that I want to say about automation, and I know I've said this to you before, automation is only as good as the person who is inputting the information. I know that I have done audits previously for organizations that, for example, want to have the system generate the CPT code for the encounter, that based on information input into the system, their EMR is going to be able to determine the level of service that's billed. And in these audits there was a lot of discrepancies, and as I was doing those reviews, it the discrepancies were coming from what was being input into the system by the providers to support selecting these levels of service. So automation is great, but it's only as good as the person inputting the information. So you want to make sure that you're doing those reviews, doing the education, taking that information, bringing it back to your providers and saying, this is where we went wrong. This is what we need to fix, providing them with that education. And then in turn, that helps you avoid those denials on the back end. Be very aware of your payer policies. There are a lot of things that are driven by a diagnosis code, and those can result in automatic denials if they're not correct. So it's really important that you understand your payer policies as well in preventing denials on the front end and just getting your claim paid versus having to go back and resubmit the claim with updated information.
Yeah. And one of the things with that too, and I have not seen this often, but there are people or practices that are still out there using systems that don't have the capability of automation. We still have some people out there who are hesitant to go to an EMR, which has its own issues. But when they do that, they're actually hurting their revenue cycle, because the practice management systems, if somebody's only looking at the cost of the system, what's going to happen if you have staff working through things who are not trained coders? That's not
Hmm.
their position, it's not their job. The providers also think it's not their job, but yet nobody works in that capacity, and the system also is not automated with edits and things like that.
Hmm.
That just wreaks absolute havoc on a revenue cycle. So we really have to look at each of the pieces separately when we think about the EMR system, and even, how scheduling flows into that and all of
Yes.
those different management things. And then we have to look at the actual encounter that's occurring, what's taking place afterwards from a documentation perspective, who is responsible for submitting the codes, and then what happens at the claim submission from there. Now, shifting gears a little bit, I want to talk about the external outsourcing of billing. This is something that we hear of quite often. And this is where, for me personally, in my experience, there's been quite a few horror stories as to how a practice's revenue has been destroyed based on, the decisions that were made or a lack of understanding of how this part of it works. So, with external outsourcing of billing, very first, I want to say, because yes, there's going to be some negative comments and conversations here. But first, I want to say that there are a lot of really good billing companies out there. My very, very good friend and supporter, Pam Vanderbilt, has a billing company. There's a lot of people out there in the industry who are doing it right. But there's also a lot more of them out there who, to them, it's more of a pushing out a volume. How big can we get our company, and what revenue can we make? And there's a very big difference when we are looking at the structure of how these billing companies are set up. And, one of the things that I've noticed when I've had to work with clients when things have gone south, it's actually been on the law side of things where they go to their attorney and they say, look, at our revenue is just a wreck at this point. We've lost out, we think, on this amount of money, and we need to get out of this contract, and we need to know what we can hold these people to. And, one thing I find interesting, I always go in and research the company. I like to see how they're structured, what's going on. One of the things that's interesting is that a lot of times I find that the companies that are just missing the mark in a bad way are the ones that are large. They have, you go to their website, there's all of these administrators, these salespeople, real top heavy in that area. Then you don't even really know who's doing the work always. And, this is where it's problematic because this is also the type of company that oftentimes will outsource. And there's a
Mhm.
lot of issues that come attached to outsource billing. And quality is a very large part of the issue that comes along with that. And, one of the other things that's frightening to me, that's very frustrating when I'm working with my clients to clean something up, is that some of these companies are even outsourcing and it's not known to the practice. I
Mhm.
think it was last year, for example, I worked with a rheumatologist who was thinking he needed to close his infusion suite. That should be an area of good, consistent revenue. And when I started to look at everything, there were big red flags that the organization was outsourcing the work based on the poor quality and the volume and everything. And they kept telling him that they weren't. And it's like, okay, well, how else is this happening? You have one US based contact person that you can talk with, and they're not following up, they're not following through. To your point before, Michelle, these different metrics that need to be in place to watch the revenue. You cannot be hands off. Just because you
Mhm.
outsource it, it does not mean that that company has your best interest in mind. There are many that do, but not everybody. And you have to be involved in this because at the end of the day, it's your revenue, it's your risk if there's issues on the compliance side. And a lot of times the contracts have, wording in there that try to dismiss them from the bad behavior.
Mhm.
Um, just to give a little bit of an insight as to what people need to be looking at in this situation, first of all, I'm also shocked when we go through the process of investigating where it went bad that there's not meetings in place. Or
Mhm.
if there are meetings in place where they talk about the issue, there's never a follow up as to, okay, we talked about this denial last time. It was because your staff didn't know where we keep the pre-authorization, but yet pre-auths are still denying and they're sitting there. My staff found them. Things like that. Yes, you have to talk about it, but you also have to come back to the table and make sure you're notified of that resolution. And that's the thing. A lot of times people will come into these meetings. If it's one of these big organizations, you also don't know how many clients they have. So
Mhm.
maybe there's too much work. They can't stay on top of it. There's a lot of things that can go into it, but the accountability has to be there. And in really bad situations, I've even worked with practices who didn't even have their own access into a system. So when we needed to run reports to understand where things were at, or when they were going through an external audit with CMS or a payer, we didn't even have full on access to go in and take a look, which
Mhm.
again, cue the attorney. We have to go down that route, and it becomes expensive and it's frustrating, and it can really cripple and potentially close practices. Sometimes they have to even think about, the future of what they're even going to be able to do. So we have to have these bases in place. You need to be notified. You need to have discussions around what you expect your AR days to look like. Do you know what an AR day measure is? Do you know that your claims, when you look at your buckets of 30, 60, 90, 120 days, I shouldn't see large amounts up in 120 plus days. We should know what's going on. Another thing I find too is that sometimes there's a lot of adjustments taking place. And when you dig into the comments and research the claim back, it was denied. For example, there was one billing company I was working with my client who was going back and suing their billing company. And when we started to, research all of these claims, it was so frustrating to see that a lot of them had passed timely filing because a request came in for notes and the billing company didn't get the notes out, or they
Mhm.
got them out 30 days late. Things like that is just sloppy AR work, and it's happening a lot, and it can get out of hand if you're not paying attention. So we
Mhm.
have to be really careful from that perspective. One other thing externally that you want to make sure you're paying attention to, I'm going to call an organization out. I don't always like to do that, but one of the things that really upsets me is when I work with clients who utilize Athena, that particular system. Athena has this built in where they basically say that you have to use, and I don't know the contract language on this, but basically when you use that EMR, you have to sign up for their billing services as well. And there's a cost to it. But one of the signs that it's going to be a bad idea to handle that is if, for example, they want their money off of what's being submitted and not off of, when that claim is completely adjudicated, paid, and
Mhm.
closed. Those are two very different things. And, every time I work with someone who's utilizing Athena, they have a billing team, supposedly, but yet my client has to have an entire department of their own because no back end work is done. So you have to really understand the ins and outs to know what you need to be asking of these organizations. When you are vetting the people that you want to outsource with, you have to go into this knowing that you don't get to, put your blinders up, wash your hands of it, and be done, because you're going to end up with a lot of issues. Luckily, with people like my friend Pam, um, I have another friend in Alaska who opened her own billing company, Andrea. These people that I know in the industry, they, like I said, they're just as involved and in deep in the compliance side of what we do. So they know what to be looking at. They want to be compliant. So they're also concerned about the compliance of the provider. So we really have to make sure that all of those things are looked at very carefully. Now, one last thing here, Michelle, and then I'm going to kick it back to you. So, I have a list here of some things that practices really need to be aware of if they are thinking of outsourcing. So, just kind of a quick checklist of some of the functions that could even be a front end function that they need to know. Okay, we may still have to have this internally, and make sure that they know, okay, my team's going to do this, an external team is going to do that. And you want that very clear in your scope of work. So when you're outsourcing, you want to make sure that you're aware of, in the process, who is going to be selecting the codes and who's responsible for coding. So a lot of times that is going to be the provider, especially if they're outsourcing. As a provider, you should not want your billing company to just change codes for you, because
Mhm.
most of the time it is very rare that a coding or that a billing contract says that they will also provide coding support unless it's an add-on service that you're paying for. So if you're submitting a 5 across the board all the time, and you see that these are coming back as 3s and 4s, okay, that could be a problem. The billing company should not just be changing codes. This is something that should be coming from the source of the person who's responsible for the coding per the contract. Prior authorizations, a lot of the times the practices will choose to keep that on. So you need to remember that you need to have staff in place for that. Same with insurance verification. Who's going in and making sure that, the patient demographics are correct, that they're entered correctly, that you have the proper insurance ID number, all of those various things. And then the actual entry. So who's taking care of the workflow of, how the codes end up in the practice management system? A lot of times it's automated, so then you need to understand who's working the edits. And then from a management perspective on the back end, that's where you want to have a lot of time frames built in on expectations. Have you even talked with your outsourced company about how quickly they're going to be working things? How are they prioritizing and looking at denials? We want to look at dollar amounts. We want to look at dates of service. Does the company know the timely filing limits that are applicable based on payer, different things like that? Is If the company knows, the question is, are they tracking their own staff to make sure they know and they're doing it correctly? Um, and then, like we've said a lot here, we've got to have the hands on. So staying in control, having those reports run. One of the things I work on with the revenue cycle reviews, if we're looking at fixing an issue in this area, is making sure that they understand the practice management system, they have access, and they understand reports. Because just like you said, Michelle, there's a lot of information we can find out just from data analytics by running
Mhm.
reports, looking at where everything's at. So from that perspective, you should have one person designated inside the practice, and make sure if it is a physician owned group, for example, that owner needs to be involved at least, at some point. It can't be all of the time one person handling it. I actually had a call last week, and it's a situation where a practice is being sold, and the new owner is concerned because the person who did the billing for the previous practice has been there for, I don't know, 20, 30 years. They're the only one who knows how to do it. And they don't even know if that person knows what they're doing because they've been there for so long. They've just done the same thing all of these years. So, again, that's another example of where you've got to make sure what's going on. So, Michelle, to round this out here, do you have any other suggestions for organizations, whether it's internal or external from that billing side? Do you have any other suggestions or comments to make on that?
Yeah, I think we've covered most of them, but definitely make sure you have a process in place so that you're always having eyes on the data, that you have a regular schedule of reviewing denials, a regular schedule of doing internal audits, have external audits done. If you're having external audits done, be open to the feedback that those
Oh,
external
that's
auditors
a big one.
are giving you. You have asked them to come in and give you their expert opinion. So be open minded to the feedback that you're being given, because a lot of times you get into a routine, into these processes. um, One thing I see a lot is overuse of the 25 modifier. Just things like that. Be open to the feedback, because that feedback can be something that helps you prevent a denial in the long run. That can help you implement education. Maybe you need a new policy in place. Maybe the policy that your organization has is not compliant and it's not going to drive good results down the road. So be open to that feedback. That's kind of my little soapbox.
Yeah.
But I think the key is be aware of your denial process. Be aware of who is looking at these and who is resubmitting these claims on your behalf. They are costly and they have implications. I mean, something we really haven't even touched on is how denials impact patient satisfaction down the road when these denials are happening. And then all of a sudden, your patient gets a bill for something that they didn't expect to get a bill for. You have patient satisfaction issues that go along with denials. So you want to make sure that you have processes in place. One, make your best effort to get that out the door correct the first time. Pay attention to your policies, know the rules for your different payers so that it goes out correct the first time and you don't have to look at it again. But also have processes in place to review your most common denials and evaluate them for the type of denial. Is this something that we could prevent? If it's something preventable, put that process into place. Put it into place so that you stop seeing that denial come down the pike.
Yeah, and I think that's a good point too with the patients. That's something we probably should focus on individually, that particular topic, because there's a
Mhm.
lot of issues with practices who, like you said, if a patient calls and says, I called my insurance company, they said you coded it wrong. Well, that
Mhm.
doesn't mean that the practice can just go ahead and change a diagnosis because they know something else is covered. Everything is just so intertwined. Every time we talk,
Is.
it just I could talk forever about it. Nobody would want to listen to it, but we we will just do that at another day. We'll have that
Yeah.
as another topic. But yeah,
Yeah.
we want to make sure that we have healthy revenue, because especially now with cuts, there's a lot of talks about, cuts in reimbursement and what that looks like from the physician fee schedule perspective and everything happening politically. And, these are the types of things that you have control over. What I
Yes.
would say is, don't sit there getting stressed out about these other things that you and I can't change. Let's take a look at what's there and make sure that you have everything buttoned up and as efficient
Mhm.
as possible. So whether you're doing that with external audit reviews, or like I said, I work with clients on the revenue cycle reviews. Those are ways that you can take your control back and make sure that you have everything in place that you need. All right, so that is the last of the episode today. I thank you for joining us, and let us know at auditingantics@gmail.com if you have any comments, questions, or future topics for us. Thank you.